Go.
Today we will be performing an abdominal assessment. We will also be removing an indwelling catheter, and we will be going over how to do different types of enemas. So before I did anything, I verified the order of the physician. I came into the room, I introduced myself, I'm providing privacy, I have all my supplies with me. Can you tell me your name?
I'm Joseph Clark.
And do you know your date of birth?
2017, on the 12th.
November 12th?
November 12th.
17th, 2012.
2012.
That's correct. So Joey, are you having any pain in your abdomen?
No.
So nothing is bothering you? And is it okay if I lift up your shirt and take a look at your abdomen?
Yes.
Okay, when we do an abdominal assessment, the first thing we're going to do is inspect, and we are going to look for any signs of rashes. We're going to note if there's any tattoos. We're going to note if there's any hernias. We're going to note just any irregularities on the stomach, and he has absolutely nothing because he's little and he's got perfect belly. The only thing we need for this is a stethoscope and an alcohol wipe. I guess now with COVID, I would be wearing gloves. So we're going to say that we're going to do this. Just organize my notes. The first thing we're going to do is we're going to auscultate, and we would start in the right lower quadrant. And we should expect to hear normal sounds every 5 to 35 seconds. Hyper would be continuous. Less than that would be hypo. And if we heard absolutely nothing, we would listen for 2 full minutes. And the only time that that would be absent would be like after an abdominal surgery or something of that. Now we're going to percuss. Right up here, we're going to listen for the abdominal aorta. We shouldn't hear any swishing. We shouldn't hear a broy sound. So we're just checking for that. Sometimes in a really thin person, you can actually see a little bit of a heartbeat. And then we would check the renal to the right and then to the left. And I'm not hearing anything. And we check for the iliac. And we would be using the bell of the stethoscope. And throughout the procedure, we would ask the patient, are they feeling any pain in the femoral on both sides? Are you having any discomfort, Joey?
Yeah.
Where you are?
Yes.
Where are you having discomfort?
Right.
Your legs being sore from football don't count as discomfort. I'm feeling for any lumps or masses underneath. This is just a light palpation. His stomach is really soft. It's not firm in any way. Now I go a little bit deeper. Am I hitting some tickle spots? That's okay. And again, I'm not feeling anything. So we'll move on. We're going to talk about removing an indwelling catheter. So when I would remove an indwelling catheter, again, I'm going to check the order. I'm going to explain the procedure to the patient. I'm going to come into the room. I'm going to perform hand hygiene. I'm going to raise the bed to a working level. I'm going to make sure the patient knows everything I'm doing before I do it. And I'm going to bring a pad with me. And I'm also going to bring some wipes to clean up the hairy area after I am finished completion. So I would have with me a pad and wipes, which would be right here. So I would ask the patient to just kind of spread the legs a little bit so that I could put a pad between the legs. I would also be, draping the patient only to expose the area. We'll just drape him a little bit. I would only be exposing the area in which I'm working. So I would put this here. Now I know in the classroom we empty the urinal, or we empty the catheter bag after we're completely finished. I usually empty it before, that way I collect everything and can dispose of it, but I guess it's depending on if they're monitoring the patient's input and output, in which case some of the urine could get lost in the tubing and then I would do it in the bathroom. But for this patient, I would put my pad right here. I would have my syringe. I would screw my syringe in, and I would let the water from the balloon just make its way out via gravity after it was full to 5 milliliters or 10, whichever much they use for a balloon, usually 5. I would unscrew it, squirt it into the pad, screw it back on, and make sure there's absolutely no fluid left in the balloon. And once there's absolutely no fluid left in the balloon, I would tell the patient, take a few deep breaths to relax the muscles and just have them be calm. And then I would just slide out the catheter and put it into the pad. I would then take it into the bathroom. Well, first I would just set it here, wrap it up, put it here, take off my one glove that I did all the procedure with, also put that in there. I would recover the patient, make sure they were nice and comfortable, and then I would go into the bathroom and I would empty it into a measuring cylinder, making note of the color, the odor, the consistency, and the amount. And then I would dispose of that. I would come back out, make sure my patient was okay. I would explain to the patient that there might be a little bit of hesitation with urinating. There could be some burning due to the irritation from the catheter. And then I would check the protocol of the facility to see when the expected time for the patient would be able to void for it to be considered a successful removal of the catheter and the patient is voiding without any issues. And then I would put my bed back into a non-working level, wherever that may be, make sure the patient has their call bell, side rails are up, do they need any help with anything else, and then I would perform hand hygiene before I was on my way. The last topic we're going to cover for today would be our enemas, and those would be our large volume enemas or our small volume enemas, and our Fleets enemas, and our oral retention enemas. For our large volume enemas, I would bring all my supplies in with me, including my bag for my enema. I would bring any supplies that I need. If the doctor ordered an additive other than soap, which would just be castile soap because it's less irritating to the mucus inside the intestines, I would have my IV pole here. It would be about 18 inches in height. We wouldn't want it any higher than that because we want our enema to go into the patient slowly. We don't want it to enter too quickly, distending the abdominal wall. We don't want it to cause discomfort. So after we did all of that and I checked my order with what I have in my room and I go over all the instructions with the patient, I provide privacy. And then we would get started. I would go in the bathroom, depending on what I'm using. If it's tap water, I would want it to be warm. You never want to put a cold solution into a patient. I would have the patient, once we're all prepped, I would hang my bag, I would add my additives. I would lubricate the end of the tip going into the rectum unless it came pre-lubricated. And then I would ask my patient if they were able to move on to their left side. Are you able to move on to your left side?
Yes.
Awesome. Can you do that for me? Just lay on your left side. That is great. And then we would have the patient lift his leg up like this, exposing the rectum. And again, we would be covering every aspect of the patient other than what needs to be exposed for the procedure. And before I got started, I would ask what the patient would want to use after the enema. Were they able to walk to the bathroom? Would they need a bedside commode? Do we need a bedpan? Those are all things that would be on hand right here. I think after he holds it in, he would be able to walk to the bathroom. Once we're ready, we're going to have our pad here. In order to protect the patient, we would just stick it right under there. We would put our enema in, and we would make sure that our clamp was close at hand because the nurse wants to be holding the enema in place while slowly releasing the fluid. Because a high volume enema would have anywhere between 750 mLs of water, which could take 5 to 10 minutes to go in on, slowly. And we don't want to walk away so that it falls out and we have to begin again. So the whole time that we're doing the enema, we're holding it in place and we're asking the patient, we're assessing the whole time. Are they feeling any dizziness? Are they having any pain? Is the abdominal area feeling like it's distended or bloated? Any of those things, you could just stop the enema and be finished, and then you could check with your physician if they wanted to do a repeat, or if it's just affected with less amount of fluid. If you were doing a Fleets enema, that has only 70 to 130 milliliters, and that's like a small kind of tube, and you would also put that in the rectum and you would squeeze it. If it's a child and you were doing it, you could hold their butt down for them for, you know, the 5 to 10 minutes or as long as they could hold it to help them retain the fluid before they have to go. After you're finished with your enema, you would put everything in here. You can wrap it up. You can throw it away. You can clean up your patient. You can then roll them on their back if they can hold the enema in place. And then you'd want to give a call bell and just let them know to ring the minute that they want to go to the bathroom. You wouldn't want them flushing their stool. You always want to be able to see their stool. You wouldn't want them throwing their toilet paper in with the stool, or if it was urine, in with the urine, because you're trying to get an idea of how much it is. You want to get an idea of what the smell is. You want to get the idea of what the color is. You want to know if you had a good outcome, because at the end, you always want to be documenting everything. You want to document the time. You want to document the type of enema that you used. You want to document how long it took, the outcome, the color, how the patient tolerated it, and sign and date it. And so I think that we covered all of that. And thanks for watching.